delivery. And Ray's thesis supervisor is Professor of Surgery and Perioperative Care at Dell Medical School, Professor Prakash Jayakumar. The floor is yours, Ray.
Thank you. Can you hear me all right?
Yes.
Awesome. Let me share my screen and get that PowerPoint up. Okay. How's it look? All good. All right. Let's get into it. So my presentation is entitled Integrated Healthcare Delivery. And as you mentioned, I was supervised by Dr. Prakash Jayakumar, and my second reader was Dr. David Ring. And this presentation is going to kind of have three parts. First, we're going to talk about why we need something like integrated healthcare delivery, which luckily Banks talked about quite a bit, so I'll be able to go through that fairly quickly. And then we'll talk about what integrated healthcare delivery is, and finally, we'll talk about my specific research project. So moving right along, the US spends the most of any OECD country on healthcare as a percentage of GDP, rounding out at about 16.9%, which is nearly double the OECD average. So you might be saying to yourself, well, okay, we spend the most, so our outcomes must be the best. Well, that's not true. We actually have, of these 11 peer nations listed, the worst outcomes in terms of life expectancy at birth, and are significantly below the OECD average by about 2 years, on par with Cuba. So, okay, maybe our outcomes aren't the best, but our quality, that's got to be the best, right? Not so. As you can see, in both 2000 and 2016, the US led these 11 peer countries in amenable deaths per 100,000 of population. And what that statistic means essentially is how many people die due to certain causes that could have been prevented by timely and effective healthcare. So for a lot of cost, we really don't get that much bang for our buck or value. So in comes integrated healthcare. Integrated healthcare delivery can help us promote value by cutting costs and shifting care focus towards outcomes. So costs can be incurred in healthcare through waste, and it's actually estimated that 25% of healthcare costs in the United States are waste. And if you'd like a round number, it's about $1 trillion. And so integrated healthcare delivery can help us mitigate that, but can also shift care towards higher outcomes, thereby increasing value, both by improving quality and reducing costs. So what is integrated healthcare delivery? Well, integrated healthcare delivery, according to the WHO, is the management and delivery of health services such that people receive a continuum of health promotion, disease prevention, diagnosis, treatment, disease management, rehabilitation, palliative care services, all through the different levels and sites of care within the health system and according to their needs throughout the life course. Now, that's very wordy, and so let's distill that down into kind of four main points that can really tease out what integrated healthcare delivery is. So integrated healthcare delivery ensures communication between providers. It ensures coordination of care across providers, so between physical therapists and orthopedic surgeons, or dietitians and social workers. And integrated care also ensures that care is continuous over time in between visits. And lastly, integrated healthcare ensures patient-centeredness, so that the patient is treated not only as a member of the care team, but also someone that really dictates what direction care goes. So how is this executed? So integrated healthcare is executed kind of through 5 different types. So one is structural integration, and this can be thought of as physical co-location of providers, in the same building, contractual arrangements between providers of different organizations. And then there's functional integration, which is how those providers who are co-located, how do they work together? The policies and protocols that really streamline coordination and their decision making. And then there's normative integration, which is essentially a culture that is dedicated to providing care to patients that is integrated. And then there's interpersonal integration, which is that team-based approach that I mentioned earlier between the healthcare providers and the patient, so that care can be delivered effectively, efficiently, and at a high quality. And lastly, there's process integration. Process integration are the organizational activities intended to integrate patient care into a single continuum across time. So let's jump into some examples. Oh, wait, would you look at that? Taco Bell and Pizza Hut in the same building. One could consider that structural integration, but let's get back to healthcare. So in practice, integrated healthcare can really occur in large systems or in small clinics. So at Kaiser Permanente in the VA, for example, in the Mayo Clinic, we have these giant systems that integrate primary care, specialty care, diagnostic imaging services, healthcare payer plans, all into one giant organization. And these are organizations that are very large, attract people across the United States, across the world, really, for their services because of how effective they are and the things that they're able to do in these very integrated, cost-efficient systems. And then integration can also take place in smaller places, like at UT Health Austin's integrated practice units, and as we'll talk about shortly, at the Duke Orthopedic Joint Health Program. And so in these smaller situations, you have clinics that bring together care providers such as orthopedic surgeons, physical therapists, physician's assistants, dietitians, and the like, to really provide a whole range of services to patients in one single clinic visit. And this is a point of integration that has been developing recently and that UT Health Austin is actually a leader in. So that's kind of in a nutshell what integration is. What did I do? So essentially in 2 words, I listened. So with my supervisor, Prakash Jayakumar, we went around to 5 different institutions across the country, specifically orthopedic institutions, and just listened to what stakeholders had to say. We listened to clinicians, non-clinical staff, executives, all kinds of people to hear what they thought about integration and about their process of implementing integration at their clinics. And so these 5 clinics were all at different stages of integration. Some were very condition focused, like UT Health Austin integrated practice units. Some were very procedure focused, like Kaiser Permanente. But we just listened to what everyone had to say, and we tried to distill a key set of themes related to the implementation of integration, and wanted to use that to inform policy across the country and maybe even the world. So let's look at our outputs of the project. So this is kind of a complex slide, but if you look at it from left to right, it's kind of going down this hierarchy tree. So the way we looked at this data, so we interviewed almost 50 people, and we coded essentially what they said into one of 21 options, as you can see by the kind of Christmas colored far right codes, which were either challenges, facilitators, or observations. So 3 there, and then each one, and there were 7 mid-level codes, each of which was related to a specific aspect of integration that I spoke about earlier, whether it be care coordination, continuity of care. And so we had 21 different kind of bottom level nodes that we coded each quote into. So we had between 50 and 250 quotes for each one of those little boxes. And I will expand the last output like that. And this is kind of 1/21th, if you will, of our outputs. We found 5 key themes for this specific thing that we looked at, and compared across the 5 institutions what they said about each of these themes. And so the research was very rich, something that I don't think anyone's ever done before. And it's just been a wonderful process. And so a few emergent findings, I mean, there were so many, but 3 that I'd like to just mention briefly, and if there are any questions about it, I'd love to take them. There are financial ramifications to integration, and unfortunately, finances can be a massive barrier to implementing integration. The second is almost every clinic wanted to leverage data in some way, whether it be for predictive segmentation softwares or something like that. Big data is something that they would love to work on in the future. And lastly, clinical leadership and making care a team sport was a very emergent theme that we saw at all these institutions. Having strong leaders that were really dedicated to the cause were very important for implementing integration. And so just some reflections to close out. this really was an incredible project. I'd love to continue with this kind of research as a professional in the future. And to anyone who's maybe a junior or senior doing their thesis next semester, I really encourage you to undergo a project that you really are passionate about and you think you'd like to share with other people. So without further ado, I'd love to take some questions. Special thanks to my supervisor, my second reader, and a research fellow that worked with us. And yeah, so thank you. That's all I've got prepared, but I'd love to take some questions.
Great. All right. Thank you so much, Ray. If you could put your slide off the
Oh,
screen now, so we're back to the multifaceted rectangles.
yeah.
Great. Excellent. Thank you. That was really fascinating. Wow, we already have a question in the chat from Drew Benedict, and it is this. Do you think privacy laws on medical information will pose an issue in thinking about integrated healthcare delivery?
Absolutely. So that is a big question. I mean, you have companies like Google who can purchase health data. I forgot which system they purchased it for, but just the word Google and health data really can cause a media outrage. And so, yeah, healthcare privacy is a barrier into having these very large systems that span states, span maybe even countries one day. So that does pose a barrier. But for smaller places like UT Health Austin, it's not as much of an issue that they're facing.
Great. Well, I have a question that's kind of related to this, and it is one relating to the role of software like Epic, which I know a lot of physicians personally who complain mightily about, the cumbersome act of having to deal with that.
Mhm.
What role do software systems play in either promoting or impeding integrated healthcare delivery?
So they're absolutely a tool for promotion. We actually had an entire code dedicated to assets, technological assets, that kind of thing. So it's something that we track very closely, and something that without fail, every providers at every institution noted as a facilitator to implementing integration. You have all kinds of electronic tools that care providers can use, from the EMRs like Epic, like you mentioned, to other predictive algorithms to segment populations like we have at the Musculoskeletal Institute at UT Health Austin. All kinds of technological assets that are very important for integrating care. Because when you think about care integration, one of the key concepts is continuity of care, which is from one visit to another. Are your records still there? Are they have they been updated? That kind of thing is infinitely easier with effective electronic medical records and the like. So yeah, very good question.
Great, thank you. And we've got a whole bunch of questions in the chat, which has lit up. So I'm going to keep going. So Darong has a question. How does integrative care relate to value-based care? Is it a subset of value-based care?
So that's a great question. That was one of the first questions I asked my supervisor, Prakash Jayakumar, when we first started researching this back in January. And the answer is integrated healthcare delivery can be considered almost the engine of value-based care. So it really helps value-based care go. So with integrated healthcare delivery, you're trying to maximize the quality you put out, but you're also trying to reduce costs. And the value equation, as they call it, is just that: quality over cost, or outcomes over cost. And so by increasing the numerator and decreasing the denominator, you're increasing the output in value. So yes, it's a very, very related concept, and very nice observation, Jerome.
Excellent, excellent. Our next question is from Nima Raman, and it is this. What specific challenges do you foresee for integrated healthcare delivery in rural parts of the US? It's a great question.
Definitely, great question. Rural health is definitely at the top of a lot of people's list of issues. I saw with Biden's new plan that rural health actually might get worse by defunding hospitals and that kind of thing. So something that's very important. But yeah, pretty much a lot of the technological assets that that these institutions bring to the table might not work as well in rural environments, but they also might provide a lot of access to rural environments. So
Mm,
one of the institutions we looked at was Dartmouth Hitchcock, and while they're centered in an academic town in New Hampshire, they have clinics all across New Hampshire, all across the Northeast, and they actually have virtual ICUs where they can have uh, intensive care personnel virtually at hospitals from hundreds of miles away
mm.
to help deliver the best possible care. And that's just a small example. But I think access implementation might be an issue. But once the technological assets are implemented, I think it will increase access tremendously. But yeah,
Great.
good question.
Excellent. Excellent. The next question comes from someone named We Love Ray. And it is this. You cited UT Health Austin as a leader. How can other care institutions replicate their success without the structural support of the university framework?
So that's a great question. The UT Health Austin integrated practice units are actually built off of a book called Redefining Healthcare by two of the world's most famous value-based healthcare scholars, Elizabeth Teisberg and Michael Porter. So yeah, UT Health Austin definitely has an advantage in that regard with the structural advantage there. But I really think it comes down to quality improvement in a incremental sense. So not trying to completely change how a certain clinic does their healthcare, but just small changes. Maybe reach out for a partnership between a physical therapist clinic and an orthopedic clinic. You know, small things that aren't trying to change the world, but really trying to change how you do things in a small way, and just continually assess what you've done with that incremental quality improvement, and just continue trying things and not trying to be afraid. But yeah, there's many other ways to answer that question, but I think that's
Sure.
one.
Great. Thank you. We also have another question here.
Okay.
And this is a question that asks, are there certain stakeholders who would resist integrated healthcare?
The doctors. Yeah, so a lot of the other frontline providers really like integrated healthcare delivery because they're not in as much debt, or they haven't spent as much time, training, and they don't just want to do surgery, that kind of thing. So there's a lot of different competing interests, but for our research specifically, it's very hard to mobilize the doctors into integrated techniques because they, at the end of the day, benefit from a fee-for-service model that doesn't incentivize value over volume of care. So that's one stakeholder. Of the institutions we surveyed, they were all academic learning institutions. So doctors who aren't in private practice, who aren't as concerned about making money because they're probably salaried. So that doesn't come up as much, but definitely the doctors in private practice might resist this.
Indeed.
And
Yeah.
the EMR companies, because they make
Yeah.
a boatload from having proprietary algorithms. And
Indeed. Right, right. Okay, thank you. That was really fascinating. So the next question comes from Prakash Jayakumar, and it is this. For traditional fee-for-service healthcare systems to make a shift toward high value integrated care, are there any particular of the integrated care stated it should or could start at outset, and structural, interpersonal, normative process? What could they start with tomorrow? Do you have any examples?
unfortunately, my Wi-Fi cut out a little bit there. Do you mind reading the second half of the question?
Not a problem.
I do
Not a
appreciate the question, PJ, but I will try to answer it. But do you mind saying it one more time?
Okay, no problem. So I will start. Okay, I'll just read it again.
Perfect.
For traditional fee-for-service healthcare systems make a shift toward high-value integrated care, are there any particular types of the integrated care taxonomy you stated that they should or could start with at the outset? That is to say, structural, functional, interpersonal, normative process. What could they start with tomorrow? Do you have any examples?
Definitely. I'm glad it came through clearly that time. Definitely.
Good.
So the organizational and process sides won't be something they can do tomorrow. It'll have to be something on the social side, which would be either normative or interpersonal integration. And I would say interpersonal integration. So what that means is teamwork, emphasizing, when they go to the hospital, that they might be a part owner and that they might have operating privileges that is in no way related to their private practice clinic. When they go there and work with their surgical team, they emphasize how important it is to be a team caring for this patient, realizing the system level impact every single suture costs the system, and how important it is for the patient to have the floor in care delivery and that kind of thing. So I'd say the interpersonal teamwork side is something that tomorrow I would love for every orthopedic surgeon in America to go emphasize.
Yes, absolutely. That is really, really great to be thinking about that as something that could happen tomorrow, for sure. Well, I wanted to ask if anyone has any other questions for Ray, feel free to put them in the chat. Um, but I think that our time is winding down. So I will just use this last couple minutes to thank all of our wonderful, wonderful thesis students for such fascinating, timely, and really productive presentations, and for your research, and just to offer such a big applause of congratulations to each of you. Really fantastic. And I wish you all the best. And thanks to the supervisors and second readers who also mentored each of you as well. So thank you so much, everyone, for